Thank you very much, Dr. Dalal, for a really very interesting presentation. And we're going to be joined by Dr. Faisal, Dr. Kumar, and Dr. Junaid Khan for the panel discussion. We have a few questions already received for all the presenters. I will start with Dr. Kumar. HLH diagnosis, as you mentioned, you need like 5 out of 8 criteria for the making diagnosis. Now, sometimes we have the diagnosis made based on, for example, like high ferritin level or high fibrinogen levels. And then when we decide to start the treatment, those levels will drop below the threshold to be diagnostic. So the question is that, is it to make a diagnosis, the only needed to have that threshold exceeded once, or you have to be persistent in the higher numbers?
Right. So for making the diagnosis, once is all you need. I continue to remind, that is the biggest message, that using those criteria of meeting 5 out of 8 is not sufficient to make the diagnosis. It is sufficient to make you suspicious that could this be HLH, but it could be many other things, or the HLH is triggered by an infection. And the last thing you want to do is give a baby who has an infection, give them steroids and etoposide. So be very careful in making the diagnosis. You can definitely suspect it, but to answer that question, one-time elevation is all you need.
Great. Thank you very much. And Dr. Faisal just joined us. Welcome, Dr. Faisal, to the discussion. Can you hear us?
Yes, yeah, I'm hearing you now.
Okay, very good. Very good. We have many questions about your presentation. The first question I have from the audience is that if you have an increased PT and APTT due to TPN-induced cholestasis, then what's the course of treatment or evaluation?
See, you have to know that if you have prolonged both, which is extrinsic intrinsic pathway, and we know that vitamin K is a fat-soluble, the vitamin, So in that area, as we know, because of prolonged TPN, and I think I mentioned in my presentation that those babies on prolonged TPN need to be given factor 7, the vitamin K. So if you can try to correct it with vitamin K, and it will be corrected unless, if the vitamin K, or if patients going for any procedures, and on urgent basis like a neonate, then you have to give FFP. Otherwise, you just absorb them or need an extra vitamin K to correct it in that scenario.
Okay, great. Thank you very much. Dr. Taha, a question about the technology of the lymphatic mapping. Many times in neonate, as you know, we see babies who get sepsis and they get severely edematous. And we always think about the either hypoalbuminemic or because of sepsis and third spacing, they get a lot of fluid leaking into the interstitium. Now, if we would suspect lymphatic obstruction for those babies, is the technology that's available everywhere that's to do for example, CT imaging, or does need to be certain like software or technology available to do this?
That's a great question. I think 5-6 years ago, there were only a few centers doing the DC-MRL or MR lymphangiography specifically. And each year we have more and more centers calling us, sending us MR lymphangiograms to review. So I think it's becoming a little more widespread. The only technology you need other than an MRI machine is an interventionalist who can insert intranodal needles followed by the injection of gadolinium. This is the preferred first step for imaging because it does show the lymphatic flow, and certain defects in the system can then be isolated What gets a little trickier is if you need to get a better look at the thoracic duct outlet, but we're hoping more information on ultrasound with contrast of the outlet would be helpful, that other people can adapt that use.
Okay, and once your imaging is done, now is it something that you need? What expertise is it? A radiologist who is going to be reading this, or do you have special training to do the reading for the lymphatic imaging?
Radiologists are reading the images at our center, and I think that's being incorporated in a lot of training programs, so that the new generation of radiologists are reviewing the imaging. But all of our interventionalists who perform the DCMRL can read the images, and most of those physicians are interventional cardiologists.
And once the obstruction is diagnosed now, and we know that as neonatologists we do some, modification of, for example, like lipid intake, feeding with MCT and all that to decrease the lymphatic flow. And so when do you say, this need to go to surgery, not to go with a medical treatment, either like by medication or by modification of feeding?
All of our patients who present with lymphatic disorders are treated medically first, including the low-fat feeds in diuretics, fluid resuscitation, removal of excess fluid in cavities that can have drains placed. And so the initial first step is, one, to make the diagnosis of a lymphatic disorder by obtaining fluid, either pleural fluid or ascites, and then trialing medical management before we take it for invasive imaging. And so that's usually our first step. And most of the referrals we receive at our institution, these medical management steps have been taken before they call us. So usually we see the patients who failed medical management.
Dr. Junaid, do you have any questions?
I have a question for Dr. Faisal, who is not around.
No, I'm not sure if Faisal's still connected.
Yeah, sure. No. Okay, go ahead.
Okay.
I'm doing between just in the clinic. Yeah, go ahead.
Oh, okay, Faisal. The one question is about the neonatal bleeding disorders. If a baby have a low platelet counts and nothing else, no signs and symptoms, no purpura, no rashes or no anything, how you take this thing as a diagnostic? That what is your diagnostic? You wait for a while, or you just act on that?
There is. I think I will. I think if you read my presentation, I mentioned on a diagram where you see that there's a different causes of low platelets, which I say patient with thrombocytopenia or not thrombocytopenia. And what you're describing is normal baby, which is not sick looking.
Yeah.
And then you have to, a normal baby which is not sick looking, then you have to, make sure. I ask you to do a family history from the mother. Is mother, she known to have low platelets from herself, or she have an ITP before? Because sometimes even she resolved, there's some antibodies which cross. And this is a cause. And sometimes the commonest error is, is iatrogenic. When you do a CBC on a child in neonates or a clotted sample or something, or if it's not full properly, the tube. The other is called, we sometimes, with e-data, you see a clumping of the platelets. So sometimes when we have a doubt, if a normal baby I will ask for citrate platelets and it will clear it out. But unexplained thrombocytopenia, you have to look for a cause. And sometimes because of stress or any, baby have, birth asphyxia, it may give it to you. But again, when to transfuse at what platelets level, it's a debate. But again, if the patient is not sick looking in neonates, we will not do anything. If below around 20 or even 10, we have to wait for it. But the commonest problem is when the either the nurse collect the sample or is the physician collect the sample. Another part is, collection error. They have to rectify it first, double check, make sure the right way, and then you diagnose of exclusion.
I have a question for Dr. Taha. Dr. Taha, you are hearing me? Yeah. So about the feeding of the baby with the lymphatic disorder, what do you recommend? There's a lot of debate with our dietitians, with our other colleagues, physicians. Do you have any specific recommendation? You said that initially you start with the low-fat feeds. So what, let's say the breast milk is available, but other than that, what do you suggest?
I'm glad that you asked that question because that is probably the number one thing I get asked from other physicians and other institutions and within our own division as well. It's a hot topic, and we typically recommend low fat, long chain. So the fat that we want to avoid is long chain fatty acids. So any formula that's low in that, if I can give some brand names without endorsing them, Enfaport is the only FDA in America approved formula for infants. However, it has slightly more fat content than Monogen. So our first line is Monogen, and that's what I would refer to other hospitals. In terms of breast milk, skimming breast milk with allowing it to layer out and then separating the fat off the top has only been shown to reduce the fat by about 20%. Whereas if you have a centrifuge and you skim the breast milk in a centrifuge, those studies have shown that the milk is actually 99% fat-free. And so if you have the ability to skim in that way, we would recommend using centrifuge first and then adding some formula for additional calories. I have veered away from recommending that because it actually, you have to discard quite a bit of the breast milk. So I will tell people to freeze their breast milk, put it in a deep freezer, because we hope that in a few months we've resolved the lymphatic disorder and we can introduce full fat feeds with breast milk.
Okay. Aiman, I have one question for Ashish also. Ashish, a very nice presentation, and if for you, if this question is like a very basic or stupid, so we are just a neonatologist. So baby delivered, and we suspect HLA. At what point of a time we should consult with you? Okay.
I would say, making sure you can hear me, yes.
Yeah.
Anytime. It doesn't matter if you are suspecting, I would say, let's put it this way, that if you think you want to start therapy before you give this baby immune suppression, and if you want to make sure, then give us a call, shoot me an email, and reach out to any of us. Faisal actually has had several encounters with me on this particular question. So any of us, you can reach out just to be sure that we're not missing. And the biggest challenge that even we face, most of these emergencies happen in the middle of the night or on the weekend, or at a time when you don't have the labs. So you have to make a decision. And in that situation, always save the patient first. And just know that we acted upon incomplete data, but that's what you have to do. Once you save the patient, and we can still confirm the diagnosis. We can do everything even after you've started therapy. The only challenge we run into is if it was a leukemia or a lymphoma, now you've partially treated it. But even then, with the genetic studies, if those are negative, then we can always stop the therapy and wait for things to unfold. So it might take a while, but if you suspect and the child is deteriorating, by all means, start the treatment, save the child first, and then we will worry about confirming the diagnosis later. But you can reach out to us at any time.
Yeah, and in addition to this question that,
Junaid, can I comment something about here? Just to take.
Sure.
I think I agree with Ashish, but one thing I think Aiman knows it. Some of the kids are only presented in neonates only with a liver failure. Apart from what you describe, any patient with acute liver failure of in the neonates, you have to think about HLH in this part of the world. We have a couple of cases in our NICU. I think Aiman knows about it. It came with QD, acute hepatitis, and the neonates turned out to be HLH later on. And we need to be very low threshold in our part about HLH, even in NICU.
So my question is related to all this, that, okay, there is chances of HLH or any disease, and usually in NICU, these type of babies, we start with antibiotics, and they are immunocompromised, and then therapy is immunosuppression. So how you deal with that situation, Ashish? Sorry for my very basic questions.
No, these are not basic questions. These are the challenges that even we deal with on every day. So yes, the disease itself causes, yes, it's an immune defect, but the HLH disease by itself does not make the child susceptible to infections.
Okay.
It is our treatment that is a bigger contributor to the risk of infection. And of these treatments, I think, believe it or not, it is the corticosteroids that are the biggest challenge. And so we are now moving towards newer treatments that hopefully will be less immunosuppressive. And that is the part that I skipped over. I did not finish it in the interest of time.
Sure.
But we now have new treatment that is approved, at least in the US. It is not approved in Europe at this stage. And that is Gamifant, which is a monoclonal antibody against interferon gamma, known as emapalumab. And I think it is available in the UAE, or at least the company is trying to make it available. And the advantage of these treatments is that they block the cytokine without eliminating or causing immune suppression. So, unlike etoposide that will cause neutropenia, these drugs don't do that. So currently it is approved only as a second-line agent, but hopefully in the next few years we will learn more. But I completely agree with you. The risk of infection is high, so we have to use prophylactic antibiotics, antifungals, and making sure that we give IVIG and supplementation, but also knowing that we should use as little immune suppression as possible just to keep the disease under control. You don't want everything to become normal. The ferritin in primary HLH will not normalize, and we don't have it to be normal. If the baby looks well and is able to, the liver function is staying normal, then I think bringing things in the safe range is all we need, and using the least amount of immune suppression. But this is even in our part of the world, it remains a very challenging disease, especially in young infants. It is still a big challenge.
And
Just I want to update you about a couple of things what Ashish says. This Gamifant is already registered in UAE, it's available. We use it for a couple of patients, I think, in refractory cases. The other thing is, as Ashish said, immune deficiency, immune dysregulation, and we are using BCG here. We come across a couple of patients with immune deficiency, trigger secondary or HLH, and then on the top of fulminant TB. So I'm not sure do we have to revise our policy to give BCG upfront here? I'm not sure, because we faced a couple of cases like this. Patient received BCG and have a fulminant because of immune deficiency, develop secondary HLH on the top of the infection, and it's difficult to treat with steroids in this kind of scenario.
Yeah, I know, Dr. Junaid, or Dr. Faisal, that Saudi Arabia, they moved actually the dose of BCG to 6 months instead of giving it at birth. Just for a chance that to have the baby have immune deficiency. They worry about kids basically, but if this is can be maybe thought of or implemented, that's a good thing to delay. I know US we don't use BCG, but here still BCG is part of the neonatal care.
Right. Well, we don't have TB is not endemic in the U.S. So yes, our populations are different. But Faisal, that's an excellent question to be considered. But you have to balance that with will the families return promptly at 6 months for the BCG? Those are the questions. I bring this up because I trained in India, and that is a big challenge we face there in the rural communities. when the child is born, that is your chance to give them all the safety you can provide, because they may not come back to the next immunization. And TB being endemic, that's what we focus on. But
now, follow-up here is very good, actually. UAE
that's
is
great.
very good. One on top of it.
Right. In that case, then perhaps delaying BCG, Faisal, that's a great idea.
Yeah.
Sorry, Dr.
Yeah.
Junaid Khan, you had another question.
No.
I think we have to wrap up because we have a lot of questions coming from you, but the time is really getting a little bit more than what they expected. But it's really great session. I would like to thank all the speakers for a very informative session. Dr. Ashish, Dr. Dalal, and Dr. Faisal. Thank you very much. It was a very good session, and please, if you can join us for the rest of the. I know Dr. Dalal is going to join us for the rest of the 2 days. Dr. Ashish, you're welcome to stay with us for the next 2 days. Thank you very much for all.